Hello, everyone. My name is Patricia Parker, and I'm the Administrative Director of Professional Education at Ufridi Manufacturing. Ufridi is pleased to sponsor this informative program on advanced dental implant care, and it is my distinct pleasure to welcome you to this event. I'm honored to introduce our speaker, Lynn Mortilla. Lynn is a graduate of the Dental Hygiene Program at the State University of New York at Farmingdale. She has been involved with the International Congress of Oral Implantologists for 18 years. She is the Executive Director of the Association of Dental Implant Auxiliaries, a Fellow of the ADIA, and a member of the ICOI's Board of Directors. Lynn focuses her work on worldwide implant education for auxiliaries. Lynn is adjunct clinical instructor in the Department of Periodontics and Implants at Temple University, and a member of the Implant Preceptorship faculty at the University of Texas Health Science Center in San Antonio. She is a contributing author to the first and second editions of Dental Implant, The Art and Science, and to the third edition of Contemporary Implant Dentistry. Lynn lectures and publishes internationally on dental implants, maintenance concerns, and office procedures relating to dental implants. Now please join me in welcoming Lynn Mortilla.
Thanks, Patty. I really appreciate the introduction, and I appreciate all of you taking some time out of your lives to learn a little bit about implant care. Tonight we're going to be focusing on assessment. I'm very grateful to Ufridi for organizing this. A lot of time, effort, and energy goes into these presentations by the hosts beforehand. And from the response of the people that were registering, we're glad to see so many people are focused on implant assessment. And assessment truly is something that needs to come at the very beginning of the appointment before you even progress onto a maintenance protocol with your patients. So we're really going to spend some time this evening just looking at the assessments from the clinician standpoint. We have a lot to cover. We have just about an hour to cover it in. We're going to break a couple minutes early for some questions. So we've got a lot to get through, but I'm confident that we'll get there with no problem. We're really going to look at the importance and the important components of assessing the dental implant and give you a protocol that will work in your practices so that you could take this information tomorrow morning right back to your office and make it applicable to your patients there. I've been with the ICOI and the ADIA. This is my 20th year. And what I learned then 20 years ago when I started is still applicable to today. Many people are confused and unsure about the protocols with implant dentistry. They continue to change, and they continue to change based on research in this field. And there is an explosion of research on implant dentistry right now, and I don't see it slowing down anytime in the future. So protocols are consistently changed and modified based on firm clinical research that is brought into the field. So we certainly will look at the research supporting all of the protocols that we discuss with you this evening. So hopefully it'll clear up the confusion that you may have or further clarify things for you. One of the things that propels implant dentistry for continual change is evolution. And it's not just evolution of society and evolution of man, but it is evolution of dental techniques, dental materials, and things that we do in the practice. Now, if you look here, you can see the very beginning. Implants were done in ancient Egyptian times, and you can see how things have grown. And somehow the explosion started early in the 50s and 60s when Dr. Bradmark placed some implants and did some research studies. And it was in the late 60s and the early 70s that dentistry really started to adopt dental implants. And it met with quite a bit of resistance in the beginning. People were unsure of it. It was a new technique. People wondered if it was experimental. Nobody was really sure where the science was going to take us. But lo and behold, things kept evolving. Research studies were done. People saw success. And now in 2013, the success rates of implant dentistry are phenomenal. They're wonderful. We've grown so much in what we have learned. But the application of new techniques, new research, and new products has really driven a lot of the changes that you will see. In ancient times of implant dentistry, if we go back to the ancient Egyptians, they used glass, they used shells. When we started adapting implant dentistry to the jaw, we used blade implants, we used subperiosteal implants, transosteal implants, root forms. And then in the 90s, the late 80s and the early 90s, bone regeneration was born. And that has changed implant dentistry more than you can imagine, because now we no longer take a patient and try to fit our devices into what the patient has. We can plan very meticulously the best treatment option for that patient, and we have the methods and the materials and the scientific data to support it, where we can plan that patient's jaw and reconstruct it with bone, with tissue, and then ultimately with the implants, which are the foundation for the prosthetics that we will be placing. So we've seen a lot of changes. We've seen a lot of aesthetic changes. We've seen a lot of ethical concerns. We've seen a lot of protocols born out of the ethical concern for implant dentistry, so that everyone is starting to practice in the same manner and mechanism on patients. If we look from a clinical perspective, from the clinician placing, restoring, maintaining implants, there are some really great evolutionary things that have happened that are really going to play into assessment, and they're going to play into maintenance. So I wanted to highlight those. The titanium type certainly has changed. We've been able to come up with better metals. Originally, we thought that pure titanium would be best, and then with trial and error and lots of research, we realized that titanium alloys are much stronger, much more applicable to chewing forces of the jaw. We've seen a major change in surface coatings and designs of implants, how we choose to restore them, the parts and the pieces that we use. And now we're focusing on different sizes, different shapes to accommodate all sorts of different applications in our patients. And we also see that we're trying to really focus on our surgery and our prosthetics so we can enhance the total outcome, because we know that it's not just the success clinically of having bone bonds to implant and having a restoration in place, but patients are discerning. They're looking at the aesthetics. They're looking at the way they look and feel, and the patients are very, very motivated to be sure that we're giving them what they want as a patient. So we're focusing our techniques to make sure that it's a success all around, from not only the clinical standpoint, but from the patient standpoint as well. If you look at the slide here, I've kind of put a hodgepodge of all sorts of different shapes and types of implants. You see the subperiosteal in the middle on the left-hand side there. You see very thin implants. You see implants that are made of different resins here. You see all sorts of different things that have been developed. And really what drives all these different developments is really research. You'll see the blade in the upper left-hand corner, which isn't done as widely as it used to be done because we now can enhance bone and make the width of bone more accommodating for a root form implant, which is more like a natural tooth. So we do see the types of implants and structures changing, and you can just see there that we have many options. And clinicians that are working with implant dentistry certainly need to look at all the research behind all of these different types of implants so that we can be sure that we're research-based in our treatment of our patients. If we look at the designs from an assessment and maintenance phase, if we're going to assume now that this implant has been placed, it's been well integrated, it's been restored well, and we're going to start to look now at the implant designs. And if you notice on the 4 pictures that you see here, I want you to look at the very top of the implant. That implant design and that Crustal design has a lot to do with how the bone grows up to the top of that implant. And what focus has come about recently over the past 5 or 6 years and is continuing with a lot of fury right now is, what is the optimum implant design to enhance crestal bone health and sculpt gingival tissue with the prosthetics to be very aesthetically pleasing. So this design right at the crest of this implant is what a lot of attention is focused on, and it's what a lot of the implant manufacturers are jockeying to find the best and do the best and create the best for us to use in our patients. But what we know about the best is what's best for the patient isn't always quickest, easiest, or cheapest. And this is a really important, factor to remember. And, there is a price tag associated with implant dentistry. And that's really out of the scope of what we're discussing this evening. But patients will often try to bargain with you or go window shopping. And it very much a conversation that needs to happen when we're talking about implants is we're treatment planning these cases for what's best for the patient, based on research and based on patient need. It's not about money. It's not about insurance. It's not about implant company. It's about what is ethically, morally, and legally best for this patient. Okay, and that's an ethical consideration that the clinicians really look at, and it's something that we will probably express at one point or another to a patient during treatment planning. There is a lot that goes into long-term implant success. And if you look at the slide here, you can see all of these things, and we're obviously not focusing on all of them tonight, but there is a lot of clinical thought and planning that goes into implant maintenance. And it's critical to our patients that we have a firm understanding of all of these different parts and pieces, especially when we're evaluating implants. Because say an implant patient walks into the practice, and if you're the hygienist in the practice, they, present themselves into your operatory, and you're going to do the initial assessment here. And maybe you find that something has gone awry. Well, the wheels in your head will probably start to spin to wonder why it happened. So if you have an understanding of all of the different parts and pieces of implant dentistry, that's going to help guide you along the way to start to troubleshoot things. So we'll certainly talk a little bit about troubleshooting this evening, but we're going to focus heavily on the assessment phase, and we'll look at some of the issues that might come up so we can start to troubleshoot maybe where some problems did happen. An implant is not a tooth, and a tooth is not an implant. And thus, we cannot use assessment parameters reliably back and forth. We have to understand the differences in the structure of the implant that we're dealing with. Now, I'm going to assume right now that everybody's got a firm grasp on teeth and how teeth develop and how teeth are anchored into jawbone and periodontal statuses. I think that's all been, thoroughly explained to us, especially if we're on this webinar. Now, what I'd like to do is I would like to go ahead and compare it to what the differences are in an implant. Now, you can see there on the screen there are some obvious differences. You've got, tooth root versus metal root in the bone. And you've got some differences of the structure where the tissue forms. Now, we're really going to look at these, and we're going to enhance these images as we walk through the differences. But let's talk a little bit about some of the supporting structures. We know that implants act as an ankylosed part of the jaw. There is no intervening connective tissue. There is no periodontal ligament. Implants do not have any type of proprioception. People can't tap and feel that they're in or out of occlusion, or they're high or anything like that. So implants act ankylosed in the bone. We know that the junctional epithelium on an implant rests on titanium. And we know at this very point now in 2013, we have no reliable way or research-proven way predictably to get soft tissue, connective tissue to grow into titanium. Now, there is a lot of focus on this, and there's a lot of research on this, because if we could get that right, an implant will be even closer to a natural tooth. But right now, that attachment is on a hemidesmosomal layer. So it's just the cells are very close to the titanium there. We know that only parallel fibers are found in the tissue around an implant, because when you take that tooth out, you lose all of the periodontal and gingival fibers except those parallel circular fibers. And what we do know about those circular fibers is they're very easily destroyed by gingivitis. And if you think about your patients in the practice now, if we were thinking about how many of our patients we see, just think about today, how many of them had gingivitis? And we know that gingivitis and the periodontal pathogens responsible for it can do grave damage to that soft tissue around an implant. We also know that the biological width is different around an implant, and this really can impact our treatment planning for prosthetics, because it's the biological width and the way the soft tissue is enhanced around those aesthetics and prosthetics that will give us the final aesthetic case for the patient. So a good firm understanding of the differences here is really important for the clinicians that are planning the case. We know that there's not a lot of vascularity around implants. We know that probing depth can often be dependent on the soft tissue depth. It can be dependent on how the prosthetic design was. It can be dependent on the abutment that we have chosen and the angulation of that abutment. The probing depth can be dependent on if the implant body was countersunk into the bone or is placed at bone level. So probing depth around implants is a lot less predictable than around teeth. We know how teeth are erupt into the mouth. We know the biological width. We know the probing parameters for them. 1 to 3 is healthy. 4 to 5 is a problem. Starting anything past 5 millimeters is an established periodontal pocket. And we know these things, but we have to liken them differently around implants because we know that every case is just a little bit different in an implant. And we'll look at some of this. Because of some of these things, we know that bleeding on probing might not be as reliable as an indicator. We also know that in certain circumstances, when the aesthetics and the tissue are absolutely wonderful around an implant, that tissue can be very, very tight. And oftentimes, in some of these cases where the tissue is very tight and adapted, the actual manipulation of just entering a probe into that sulcular area around the implant can actually cause a small amount of bleeding. So we're not going to look as heavily on bleeding on probing as a parameter for health versus disease. We know that implants, healthy implants, do not move in the socket. They are ankylosed. If there is movement of an implant part or a piece, that requires immediate attention by the doctor to see, is it an implant part or is it the implant? Because a loose implant is a failed implant, but oftentimes it's parts and pieces. And again, just in repetition, there is no proprioception around implants. What we focus a lot of our assessment on is the perimucosal seal or the permucosal seal. That is the biological seal or the tissue barrier that it represents itself just as the sulcus would around a tooth. And this seal is a barrier to the oral cavity, and it works to keep bacteria, food out of that sulcular area. It is very important that the perimucosal seal be healthy, just as it's very important that the sulcus and the gingival tissue around a tooth be healthy. Same thing here with the perimucosal seal around an implant. Now, for those of you who may never get to see the assisting phase, the restoration phase of some of this, I wanted to really show you some different angulations and show you what a perimucosal seal is. And I've done it best with these slides here. On the upper left of the screen, you can see that there is abutment in that perimucosal area. To the right, that singular slide, you're actually looking at the body of the implant. There is no abutment in there. And you're looking right down through. There's, a narrow channel in the middle of this implant, and that's what you're actually looking at. And you can see how beautifully that soft tissue has been sculpted. And in the lower left, I'm just showing you from a different angulation of what this soft tissue looks like. Now, I'm showing you 3 very beautiful cases. To achieve this type of success takes a lot of time, effort, and training on the clinician side. And it's often, a lot of treatment planning. And sometimes it's multi-clinician cases where clinicians are working together. There may be somebody that places, there may be somebody that restores, and people are working together to get these type of results. Other than the sulcus area, one of the things that clinicians often look at when they're treatment planning is bone. And if we look at these different images here, you can see varying widths of bone, all the way to the lower right where the jawbone has been so resorbed that it's unidentifiable. And this is one of the essences of treatment planning, how much bone is there. And one of the great things is we have wonderful ways of augmenting bone and growing bone for our cases. And, based on the patient type and based on the ultimate long-term goal for these, we have a lot of different ways to do it. It's a little bit out of the scope of what we're talking about, but I want you to be aware from an assessment phase that, this is where the bone starts in the pre-treatment planning. And if there's not a lot there and we're trying to build it, it's going to take a lot of time, effort, and energy on the clinician's part, as well as there may be longer healing times involved and longer treatment times involved. So this is where, when we say it might not always be the fastest, this would be what I'm talking about, that some of these cases may take a little bit longer. In adjunct to bone resorption that you just saw on the previous slide, we can also have some changes in tissue, and tissue can resorb as well. I just wanted to show you a chart here, a very important chart from a maintenance perspective and from an assessment perspective. What kind of tissue are we dealing with? Are we dealing with keratinized tissue or non-keratinized tissue? And you can read off the attributes, the pros and the cons to both of them there. But one of the things that I want to call your attention to is you're probably pretty familiar with cases of non-keratinized tissue, especially if any of you are perio-focused. We look at, tissue grafting in these cases. We know that non-keratinized tissue is very loose, allows a lot of bacteria to build up. It can be very sensitive for the patient, non-keratinized tissue. So all of these things would significantly impact some of the great successes that we might see from an aesthetic standpoint, or maybe a patient maintenance in terms of oral hygiene care of what the patient is allowed to do. So the type of tissue that the patient has there, one of the things that we are going to assess and we are going to evaluate is it keratinized or non-keratinized? We spoke about circular fibers, parallel fibers. Those parallel circular fibers that are only found in keratinized tissue. So if you're dealing with a case where the abutment comes into the mouth in a non-keratinized tissue area, those parallel circular fibers will not be present in that tissue. And it can cause some aesthetic challenges, it can cause some oral hygiene challenges, food entrapment challenges. So that's a really important point to be aware of when you're assessing things. Let's take a look here at pre-restoration and post-restoration. And what I really want you to look at is the crustal bone. We know that after an implant is put into function, that we can see changes to that very top crustal bone area. We normally, and it is acceptable, to see 1 millimeter of bone loss at the crest 1 year post-function of a restoration placed on an implant. Now, there are a lot of different theories, a little bit beyond what the scope of what we're talking about tonight is. There are a lot of different theories of why this 1 millimeter of bone can be lost, but I want you to be very clear and aware that during the assessment phases of implant dentistry, if you see 1 millimeter of bone loss at the crest, do not assume that there is a problem. There are things that happen that we will talk about in subsequent slides that are responsible for causing this millimeter of bone loss, and it's completely acceptable. Now, one of the things that we've seen recently with a lot of research and focus on design is implant manufacturers are really focusing on that crustal area of the implant and the connection of the abutment and that implant abutment connection. And they're focusing on this and researching on it because there have been some research studies that say that the way that the top of the implant is designed, the way the restorations are placed on there, can either enhance this area and cause less crustal bone loss, or if it's not done well or the right components are not chosen, can cause more crustal bone loss. So that's one of the things that is out there in research that people are looking at. But if you look at this slide, you'll see that right side, that crustal bone loss falls about to the first thread. And a lot of times we see that because there's a very smooth top surface to that implant. And research has indicated that bone wants to grow to a roughened surface. So it will find that roughened area, and that's where it will maintain itself. There are some research studies that have looked at the adaptation of the abutment to the implant, as you see right here by this second yellow line. And there is some research that says if this adaptation of the abutment to the implant is not perfect or not well seated, that will cause some problems. Some people have tried what we call platform switching and moving that abutment surface interior onto the implant so that if there's any micro gap that happens. Any bacteria that might rest in that micro gap are moved internally to stay away from that bone, crustal bone level. So there are a lot of things that people are trying to look at, and another focus is where that implant, how it is placed in the bone. Is it placed at bone level? Is it placed below bone level? Is it placed above bone level? And all of these different things that we're mentioning are going to try to enhance that crustal bone and prevent it from being lost any more than that acceptable 1 millimeter. What we have learned in implant dentistry is a lot of protocols. We've got it figured out how bone grows. We've got it figured out how tissue grows. And what we've done is we've adapted that, and we've researched, and we've come up with protocols because we know the exact amount of millimeters and planning that we should put onto a case so that the space between implant and implant, or implant and tooth, is adequate so that we can get crustal bone to grow down and tissue to grow down. We know we will look at the contact areas between teeth or prosthetics so that soft tissue, if these are individual implants or a crown and bridge case, so that the tissue will look very natural, that these crowns or prosthetics look like they're coming out of the tissue. We know this beyond a shadow of a doubt. There's some great research. This is a sketch by Tarnow. ICOI has a glossary of implant dentistry. In the back of that glossary of implant dentistry, all of the millimeters for planning a case to get optimum aesthetic, prosthetic, and bone success is listed there. And, you know, that's what doctors will learn and develop in their treatment planning skills. And we know that when we can apply all of this research and all of the science and all of the treatment planning, that we can hopefully get a great result. Now, when you initially look at this slide, you're like, oh, that looks pretty good. I'm going to have you focus in a little bit. We are talking about assessment. If you focus in, you can see that this contact is a little light right in the middle of these two anteriors. You can see that there's a little black space there. You can see that there's a little bit of a graying. You see the abutment here. You can also see that this gingival crest is a little bit higher here. We can see that the width of this anterior incisor is a little wider than the natural tooth. So when you really start to assess and look a little closer, you can see a couple of inadequacies in a case like this. For, you know, all general purposes, it looks great, but when you really start to look at it a little closer, you can start to see some of these things. And those are the things that we work very hard in treatment planning to work out. I wish I could give you a black and white. But like everything else in dentistry, there's a grayscale. And if I can quote Dr. Carl Misch from Contemporary Implant Dentistry, the 3rd edition, this grayscale of decision-making makes it hard for us to make rules or decisions. You know, they're not always correct for everyone, so we really need to identify each patient specifically. We need to work out treatment plans specifically associated for patient need and what the patient presents with, which can cause some problems because it's going to require differences in opinion among clinicians, and it's going to require you probably to move out of a comfort zone. And there'll be a lot of things that change in implant dentistry as time goes on that's going to cause some changes to these protocols and new procedures and new tools that are on the market. You know, I never thought 20 years ago when I started lecturing on this that people would have CAT scanning devices in their offices. When I started lecturing on implant dentistry, we could not grow bone or soft tissue. And here we are in 2013, and those treatments have changed because the research and technology and materials have changed. So what we do for our patients can change. And I'll tell you, this is an expanding field, and we will see a lot more change. So being responsive to change is always incredibly important. When you make your decision for your patients that are in your offices, there's a lot that's going to go into it. Scientific evidence is where you've got to base your knowledge and skill set. You've got to look at the science, and you've got to find the correct science that is applicable to those patients. Then you've got to look at the clinical criteria of the patient that is there. The clinician has to add their experience and judgment of the case, looking at other factors like the health history, other other teeth in the mouth, other oral conditions, systemic conditions, and then of course, what does the patient want? What are the patient preferences? And all of these are going to go into the decision-making bubble. And I wish I can give you that clear black and white, but this is where the gray comes in because there are a lot of parts to this puzzle. But it's all collaboration between the team. Not only the clinicians, be it a surgeon and a restorative doctor, but assistants and hygienists and their assessment phases with these patients are equally as important to go into the treatment planning. It was Mombelli and Lang in '94 that first published that hygiene should be part of pre-surgical treatment planning. Hey, if a patient lost all of their teeth due to neglect and lack of oral hygiene care, that should really be something that you think about before you give them, a whole mouthful of implants and send them out into the world. Has the patient changed their habits? And how are we going to need to re-educate these patients to be able to take care of the implants and the restorations that we're giving them? Maintenance doesn't equal prophy. And this is really a really important point that I want to talk about because we're not even getting to the maintenance phase of implants this evening because it's so important that we set the cleaning portion away from the assessment portion. Both the assessment and the final care that you render to those implants makes up the whole maintenance. It's not just the scaling part. And I hope that's what you leave here this evening understanding. The whole maintenance phase happens under dentist supervision, and we know that auxiliaries are very empowered and very educated to know what needs to happen during those appointments. And what we're really going to focus on tonight, and we're going to get into now, is the protocols. It's the protocols of doing the different examinations and assessments so that you can collect the data, share it with the dentist, and ultimately decide how the implant is doing. So you will have this evening at the end of the presentation, there are going to be some downloadable handouts, and one of them that you're going to be able to download is the implant assessment form, which I'm going to have up on the screen here in just a minute. But what you're going to be assessing with these cases is tissue. We've talked a bit about tissue already. We're going to talk about bleeding, exudate, bone level, occlusion, mobility, and hygiene, of course, is really going to be, we're going to take off on that in the next section. But let's take a look at some of these phases, and let's take a look at cases. When you're assessing, the first thing you're going to do is just look. Do you ever look at somebody's mouth and in your mind you just keep saying, something's not right here, something's not right here? It's that little intuition, that little voice inside of you. So what do you usually do when that little voice starts talking to you? You start to probe further. You ask questions. You look around. Maybe you call another clinician in, another hygienist, or maybe the dentist in. But you have to look around first, and you have to, chart down what you see, communicate with the patient, and then customize the approach for your care there. If we were comparing the two pictures here, top and bottom, you can probably, just by looking at these pictures, see some very different things. Upper slide has saliva, whereas the lower slide is a xerostomach looking mouth. You see some redness on the lower slide. On the upper slide, when you look at that tongue, you can see some plaque across it. The upper slide, you can also see some of the abutment, the metal poking out at the gingival area. You see some wear facets on the premolar. So, what you originally start to see, write it down. This is part of your assessment of this case. This is the checklist that you're going to be able to download. Some of it may be up there for some of you to download. I know you see a couple of different things than I do. But this is the implant maintenance checklist. And everything that we're talking about tonight is on this checklist so that you have an easy method of going through things without forgetting anything and being sure that you capture all of the instrumental information for these assessments of these implants. The next thing we're going to look at is what type of restoration is in place. Now, I'm just going to walk you through, and in the essence of time, unfortunately, I can't really expound on all of these different types of restorations. I'm just going to give you a couple of highlights on them. But we're going to look at the restoration next, and we're going to look at how the restoration ties into that implant abutment. What you're looking at here are overdenture restorations. That upper half, those are the yellow little clips that you see there, are Hadar clips. And they attach to the bar, on that case on the left side. And that is a bar, and those abutments are built into that bar. And that denture locks onto that bar. One of the things from a maintenance perspective is we're going to check these clips. We're going to check any of these housings. Does anything look like it's loose? Does it look like it's broken? Is it full of calculus, plaque, tartar, any of that? Are any of these pieces missing? The overdenture restoration at the bottom, those are O-ring attachments. And those O-rings fit right onto those metal struts in that bar abutment conjunction there. And you'll notice that they look like little rubber washers, and that's exactly what they are. They are stress breakers. And their purpose there is to absorb stress and load. Those attachment mechanisms come in different sizes and shapes and colors, and it's very important that when this case is developed by the lab and the doctor, that we never, from a hygiene perspective or an assisting perspective, we don't place the wrong color in there if we're replacing these. We always follow the same scheme, and doctors will, if they need to apply more pressure, add different types of O-rings, denser ones, or different densities so that they can achieve the purpose of displaying that load correctly. This is a different type of overdenture restoration. These are called locator attachments. And they come again in different size, shapes, and colors, and they fit onto those abutment housings that are on the top of those implants. These again can wear down and need to be changed, or I've seen them filled with calculus that the patient can't even seat the overdenture and they think there's something wrong, and it's because they've become full of calculus or food debris or something like that. So those are your overdentures. Then we also have different types of fixed restorations. Now, you can see here some of these fixed restorations are pretty unique. What we really try to do, instead of replacing soft tissue, anywhere you see pink on these restorations, with porcelain, is we really try to change the type of implant we're putting in or treatment plan it so that we can build more bone or soft tissue. But a lot of these restorations were done before we could replace bone or soft tissue. They're still healthy, they're still functioning in mouths, but they are highly maintenance intensive. Anytime you have something that's all connected this way, the oral hygiene care that the patient can provide becomes very, very crucially important. Cement retained restorations that aren't adhered together, they aren't bound together, that work as single teeth, you floss them like single teeth. Unfortunately, if we bind those bridges together, we're looking towards a floss threader to use for cases like that, and people would treatment plan that type of restoration if they needed more support, or they were challenged in terms of the patient's load that had to be applied to these areas. So all of those things go into that type of treatment planning. On those cases, you'll see here some screw retained restorations. You know, to an unknowing eye, they might look like root canal access holes, but what is actually under those are some screws. And I've put one on the lower left-hand screen so you can kind of get a feel in your head for how it works and how that screw inserts into the middle of that implant. Now, anytime you start to add more parts and pieces in some of these screw retained restorations, understand that some of these internal screws can become loosened, and that can mimic mobility. So when we talked about earlier, and we're going to talk about in a couple more slides, what is loose if you find some mobility, we definitely would want to see if it's a part or a piece or the actual implant body. One of the newer techniques that is trademarked to Nobel Biocare is the all-on-4 technique. And basically, if we look at what this is trying to do, this is trying to distribute load a little bit differently. Some people have heard about the teeth in a day mechanisms, or how people can get teeth replacement faster. And it's based on distributing load a little bit differently in the bone. And as you can see from some of these restorations you're looking at here, they fit very snugly up against the soft tissue and bone, which we'll talk about in our next webinar, some of the challenges with maintenance here. But from an assessment phase, you may not be able to see that abutment or see things well, and you may have to rely more on radiographs. We've talked already about the soft tissue and what types of soft tissue are available around implants. We know in health the soft tissue around an implant is very similar to healthy soft tissue around teeth, that connective tissue is closely adapted to the implant, it's tight, it's pink, it doesn't bleed easily, and the opposite is also true. We know that soft tissue in disease can be red and cyanotic, can be enlarged, cratered, you could see bleeding. Exudate the red flag should go off if you see exudate. The whistle should blow. Understand that exudate, pus, infection is happening. It's active. Exudate means active infection. And that is truly one of the most trying things around an implant. And it is one of the things that can cause implants to have serious problems around them, get bone loss established around them. So it is something that if you see exudate, you must take that very seriously because it's an active infection. Hemidesmosomes, we talked about that in circular fibers. When we talk about this soft tissue, I want to talk about the probing differences. And if we look at the slide here on the left, understand that when we're probing around a tooth, what we're doing when we're probing is we're trying to assess where the crustal bone is. And what we're doing is we're bouncing on fibers. When we look around an implant, that meshwork of periodontal fibers that we bounce on with the probe is gone. And we're left with these parallel circular fibers. So our probing technique needs to be a little gentler as to not rip these fibers, which can happen. And we need to just have a better understanding of where our probe is resting and how close it is to that crustal bone that we don't want to disturb that tissue. Well, we do know that we need to be probing our implants because probing is going to give us an incredible amount of information as to where that crustal bone is. But this image really enhances the clinical difference between tooth and implant. And I think now that you can see it, you can rest assured that you're not going to do any damage by your probing if you're probing gently. But let's look at a couple of, other concerns. Why do we have to probe gently? Well, we also know that this seal, this soft tissue, isn't very predictable. And we know that if there are periodontal pathogens in there, gingivitis pathogens in there, we know that we can have some breakdown of these tissues. We also know that we can penetrate this junctional epithelium. And if you penetrate this junctional epithelium, it takes about, 7 days for the tissue to reform, but it will reform. We know that it leaves us closer to proximal bone than we want to be. And sometimes it's very difficult to get parallelism to the long axis of the probe, and we can't get all of the sites that we want to attain. So it's for these reasons that we want to be very careful in our probing technique. We have resin probes that are available for us to use. If you note here, the visibility is wonderful with the color view probe here that you see. It is a resin probe, and it has some wonderful features to it. It is rounded and it is soft at the end, and there has been some great research that proves that the comfort factor of resin probes are great. If you look at the slide here, you'll see that probing technique is very important. Angulation is incredibly important because you want to probe parallel to the long axis of the implant because that is how you are going to get the most reliable reading. Now, if you look here, the parallelism here is incredible. You can also see the visibility differences between these two probes. And we also know that the research by Gerber absolutely shows that rounded resin probes are much more comfortable for patients during the implant probing technique because patients can be more sensitive in the implant area. So that's real important to look at. What are some of the parameters that you should follow? A gentle probing pressure using a fixed probing point. The first year after restoration, we want to evaluate all sites for color, form, consistency, bleeding, and depth. After a year of stable probing that hasn't changed, it's acceptable to use x-rays to look at the mesial and distal levels. We always want to correlate probing depth and bone loss. If you see bone loss on an x-ray, pick up a probe and probe. If you're probing and you see an increase in pocket depth, you want to take a radiograph. So you always want to make sure that you couple them together. You do want to yearly probe these cases. Or if you see a problem, you want to go ahead and pick up a probe and probe if you do start to see some problems. And again, if you look here, you can see the parallelism of these probing techniques is excellent. That's what's going to give you the most reliable indicator. Now, you have many different types of tips that you can use. In addition to probing your probing depth, you're going to chart the attachment level if there is some recession in these areas. And these probes, the black lines, are very highly visible in the mouth, even posteriorly on the lingual side with the tongue in a way and in pools of saliva. So these are definitely times you want to look at these. You're going to get about 30 autoclaving cycles out of the ColorView probe, which is great from a financial perspective. And then what happens is the markings will start to wear with the normal use, so you'll replace those tips. And they're sterilizable. You just screw them into your probing handle. If we look at radiographs, those are also very important for our assessment phases. We want to make sure that we're getting diagnostically acceptable radiographs, that we are seeing the threads of the implant if they're threaded implants, while a panoramic x-ray is great to give us some information. It doesn't help us look at that crustal bone, and that's really what we need to see. Okay, we don't need to see the apex. We're looking at that crustal bone interface. We know there might be slight changes from baseline. We talked about that millimeter of bone loss, so that's completely acceptable. We want to be sure that when we're taking our radiographs, we're capturing the most apical portion of the bone to implant interface. We know that vertical bite wings have the least degree of distortion. Sometimes, especially in completely edentulous cases that have been restored with implants, we have some difficulty positioning for parallel periapicals. Sometimes we have to use different types of holders and different types of stabilizing devices, or use smaller pedo sizes to get a good radiograph. In many research studies that you see, they will use implant pitch as a marker, and the pitch is the space between the threads of an implant. We usually do not denote things in the office by pitch, but you may see implant research like that. So a radiographic protocol to follow: we want to take diagnostically acceptable. We want to make sure that we can see the implant crest, implant to bone crest. If we see an abutment implant connection, it should be a clear line. We want to rely on the assistants and our doctors to help us be sure that we get a baseline radiograph at prosthetic delivery. It'll help us make sure that everything is seated correctly, but it also give us a comparison. At 6 to 8 months after that, you're going to take another film. And at the 1-year mark after restoration, you'll take your third film. You'll compare all 3 of these films and look at the overall case, look at probing depth at that time. And if you see no changes, there's no probing changes, there's no bone changes, other than maybe a millimeter, and the patient is completely edentulous, you can wait 3 years to take another radiograph. If the patient does have teeth, you want to take yearly radiographs, unless you see other clinical signs, symptoms, or problems, in which case you're going to make sure that you radiograph, and if there's a problem that you've got to fix, you want to radiograph every 6 to 8 months until you have 2 stable radiograph cycles where there are no problems and you are sure that the problem has been solved. So those are incredibly important parameters to follow to be sure that there's no early signs of problems. Now, let's take a look here. What are we trying to identify? Some of the things that can be wrong. Well, when we look at the left, we see that there are 2 implants with 1 crown placed over it, and that is excess cement between those 2 implant abutments. We can see a periapical pathosis going on right here in this unfinished root canal. On the other side, with this vertical bite wing, we can see that there's some periodontal problems happening in the maxillary area, like severe periodontal problems. So there's a lot that we can tell from radiographs. And again, we're assessing, we're collecting all of the information. Here's another case here where you can see there's a little bit of an angulation of the implant here. It's not completely straight in the bone, but you can start to see that there's some shadowing going on here. There seems like there's a little bit of bone loss getting started here where the bone levels are a little bit further down on the distal side of that implant. So again, collecting of the data, we're not only looking at this implant here in the mouth, but we're looking at it on radiograph to see if we can identify any problems. two different mouths here on the left and right side. On the left side, we see that two crowns have been connected, which we do not do anymore in implant dentistry. We know that the difference in the ankylosis of the implant and the periodontal ligament of the tooth can cause some serious problems. We can also see, some other things going on the maxilla. We can see that the angulation of this implant is kind of off skew. It's not parallel to the biting surface. That implant isn't placed parallelly there to absorb the load. So we see those problems. Here on the right side, we can see again, we've tried to connect teeth and implants, and boy, did that tooth give up. We can also see right here, you can see a very small spacing between the abutment and the implant. So, these are assessment things that definitely need to be, raising some flags in your head, and documentation of these issues is also critically important. But the one thing that I can't stress to you enough is watch that crustal bone. We know that after restoration, we're going to see about 1 millimeter of bone loss, which is what you're looking at here, to the first thread. So that 1 millimeter of bone loss has happened here because you can see how high the bone is here before it's restored. And this is about a year after restoration. So watch that crustal bone. That's going to give you the biggest indication if there's a problem. Now, if we do see some crustal bone, then the next logical question that comes in is why? What can be causing some problems? Well, we talked about them a little bit before. The abutment connection can be off, and you can see that in that slide here. Maybe that implant was sunk very deep into the bone. Maybe that smooth neck on the side of the implant is causing the bone to run to the roughened surface. Maybe our prosthetic tables are very deep and the bone is following underneath those prosthetic tables. Perhaps we have excessive strain or stress or occlusal forces, or we've connected this to a tooth. The other thing that will cause some crustal bone loss is frequent component change. Just because something is screw retained doesn't mean we should take it off at every visit. Okay, it's screw retained for the way that the prosthetic was designed, but it is not supposed to be retrievable for maintenance purposes. Bacteria is, of course, another reason why we might see crustal bone loss, as you can see in this case here, or stress, overstressing. This screw is broken because something just didn't fit right or wasn't designed right. There was too much load here, and we saw this screw break. There's too much load here, or that load isn't evenly distributed, and that placement of that implant leaves something to be desired, and that's why the load is altered there. We've already spoken a little bit about mobility. I'm going to repeat it here for good measure. If the implant is mobile, it is a failure and it needs to be removed. However, what is actually mobile, the implant body or the prosthetics? One of the main ways we look at to decide which one is possibly the culprit, is it the implant or is it the prosthetic piece, we can use our air water syringe tip. If the mouth pools with a little bit of saliva, or we blow a little bit of water in there and we blow our air water syringe tip, we blow some air in, oftentimes if it's an interior prosthetic screw that is loose, you'll see some little bubbles of air that is escaping from around that screw, and you'll see a little bit of percolation. So you can try to rely on that if you're sensing some mobility, but this is definitely a time when the doctor has to get involved to see what's going on. We can check mobility with some mirror handles. You're seeing some resin mirror handles here. You're not going to do any damage if you use metal handles, because you're really not adhering any stress to that implant that's going to scratch it. You'll also see this is a stability meter. That is another thing clinicians, and that's for doctors to use. It will resonate a sound or a pitch against the implant to see if the implant is well integrated into the bone. Occlusion is very important to be checked routinely for our patients. Absolutely once a year, because once we have occlusal damage that is done, it's hard to correct. In very maintenance-intensive cases where you have a very intricate prosthetic design or multiple units of implants, we definitely might want to think about checking occlusion more than once a year. And it must be notated in the chart that the occlusion was checked and whether the occlusion is acceptable or needs to be changed. So what are some of the things that might crop up that you might see during your initial view around the mouth? Well, you might see inflammation or bleeding, exudate. The patient may complain of bleeding. Maybe you're looking at a radiograph and see some loss of bone. Maybe the rest of the mouth is starting to have deterioration for some reason, or the patient's health status or medical history has been compromised, or you're noticing some mobility or probing depth increase, or patient is complaining of a problem or pain. These are all factors that you find during your assessment that require you to really focus, get the clinician, the doctor involved to get to the root cause of the problem before any of these start to cause significant amounts of bone loss. So if you're a hygienist and you're listening, in addition to the education and motivation you provide for your patients, you're going to do all of these assessments that we talked about and evaluate them and document them. Work with the doctor to identify and resolve problems. The next webinar that we go to will talk about removing any type of deposits and the patient-specific oral hygiene routine and a recall schedule. So we're halfway through our journey. We've got through the whole assessment phase, and the evaluation is only half as important as the documentation because they have to go hand in hand. So it's very important to make sure you document your findings well. The next best thing to knowing something is knowing where to find it. I hope this evening I have taught you how to find some things. I invite you to take a look at some of our websites at the ICOI and the ADIA. I know I have a lot of our ADIA members on the line with us tonight. Thank you for being here. We hope that if you have further questions that we can be the society that helps educate you and provides you the resources that you do need. I thank you for your attention. We're going to open this up. We're going to start to take some questions. And I appreciate everything that you've sat with me for. We'll have some contact information on me. Here we go in just a second, so if you need to contact me. But I think we're going to open up for questions now. As I'm clicking through some of the questions here, I saw one that said some of the periodontists do not recommend probing. I know there are a lot of older thought processes that, nobody wants anybody to damage anything with probing. And I think it's very important to say that probing is an essential assessment to this, especially when we're trying to probe when we're trying to assess where bone levels are. So that's definitely something you want to go ahead and, if you want to have the conversation about the research that is out there, the research is very. Patty, you might want to mute yourself there. Definitely something that we want to look at. I see some other people here saying they went to a seminar regarding the dental implant by the surgeon and said probing is not necessary unless there's a suspicion of something going on. Well, again, research does prove that probing has its place with implant dentistry, and sometimes just looking at something isn't going to give you enough idea. You'll never be able to see buccal or lingual on a two-dimension x-ray, so probing is definitely supported. Again, you want to follow the parameters. You just don't want to, probe this like it's a tooth. You want to really go ahead and be careful about the probing techniques that you are using, making sure you're parallel. So it's really important. I have somebody here saying I work under a periodontist and you're required to probe all implants at the maintenance appointments. That's great. As long as you're being gentle and you're doing all that's exactly what you need to be looking at. I've got a question here about scalers. We're going to hold that till the May 8th. Webinar, so I hope you're coming back because we're going to talk all about the research related to scaling and maintenance on that webinar. There are some handouts on the left that you can download that will have tons of information, as well as there are some articles on Friends of Q3D that I have written in written format that really goes over everything that we've talked about. And if you need any of those websites, go ahead and email me, and I'll be more than happy to send those to you if you need those.
Well, I'd like to thank Lynn for an excellent program this evening. We hope you identified some concepts that will be useful in your practice and help you to perform at your best. Thank you all for joining us, and we look forward to connecting with you on a future webinar.
Thank you, and thank you to Hugh Freedy. Good night, everyone.